Well, let me first and foremost welcome home David Fajgenbaum. I had the pleasure of meeting David's father, actually, when he was in his graduate training in orthopedics at the University of North Carolina. If you saw young David play quarterback at Georgetown, he could actually bench press enough to have been an orthopedist. The good news is, for us, fortunately, that's not what he did. I did not meet his wonderful mom. He lost his mom in David's first year, and as typical of David approaching grief and problems, he founded the Students for with Ailing Mothers and Fathers. That's now a foundation of 2,000 plus members on 23 campuses, and he still works for that. David graduated from Georgetown, completed a master's in public health at Oxford. Despite my efforts, he went to Penn at medical school. He met other Hoyas, John Morris and others, but he also met the inimitable Arthur Rubinstein, who founded the Center for Orphan Diseases, and David has served on that board. But David completed his MBA at Wharton and brought those colleagues into the fight. I hate to say this, but it may have been providential that David developed a life-threatening illness no one could fully diagnose or treat. He spent that early career doing what no one else could do, connecting patients, clinicians, and crowdsourcing the diagnosis and solution of idiopathic multicentric Castleman's disease. He created the Castleman Disease Collaboration network to answer research questions for the first time, bringing investigators together, using FDA-approved solutions, and always, always bringing hope. David is an NIH-funded investigator. He's part of the Forbes magazine 30 Under 30. And he, I think, was one of the youngest, if not the youngest, faculty member appointed to a faculty appointment at Penn. I'm going to make the one plug. Don't wait for the movie. Read the book. It took me 2 days and a couple of boxes of Kleenex, but it's great work. David, we are proud of what you've done. Welcome home. I know there's more to do, but we can't wait to hear about your work. Thank you, David.
Oh, Dr. Mitchell, thank you so much for that warm introduction, the warm welcome back to the hilltop. I wish of course we were in person today, but really it's such a pleasure and an honor to spend some time with you all today. And as I learned right before we began this session, I just learned that Georgetown basketball is playing right now. And so I'm slightly regretting I mentioned that, because I'm hopeful that you guys don't all drop off the call to check out the Big East tournament. But I'm particularly thankful that you all have videoed in instead of checking out the Big East tournament. And hopefully you'll take some things away from this. So I'm going to start out by sharing my screen. And I just want to highlight the talk that I'm going to share with you all today. My goal is to share the journey that I went down searching for a treatment in my own case, really with the goal of you all taking away lessons to be able to apply in your own practice in the work that you do. So the title of the talk is Personalized Medicine and Lessons Learned from Chasing My Cure, which hopefully will make a little more sense as the talk goes on. I'll share my perspectives from physician, researcher, patient, advocate. Talk a bit about Castleman disease and other cytokine storm disorders, and finish up by discussing drug repurposing. My disclosure is that I've received research funding from Janssen and from USA Pharma for a registry, and study drug for a clinical trial from Pfizer. So I mentioned that I'll be sharing some different perspectives, and just as Dr. Mitchell shared during my introduction, the first perspective that I'll be sharing today is that of the loved one of a patient. My mom was diagnosed with brain cancer shortly after I arrived at Georgetown as a freshman, and her illness and her battle with brain cancer inspired me to want to go into medicine. She passed away my sophomore year, and I decided at that moment that I wanted to go into medicine. I wanted to be a part of searching for treatments for patients like my mom. Fast forward a few years, as Dr. Mitchell mentioned, I went to Penn for med school, and I will be sharing this sort of physician perspective throughout my talk today. But what was so surprising and unexpected was that during medical school, I became a critically ill patient myself. So I started experiencing multi-organ system failure and spent months and months hospitalized on dialysis with a feeding tube, needing daily transfusions, really, really, really sick. I was eventually diagnosed with a disease called Castleman disease that some of you all, I hope, are familiar with. But I became quite aware quickly that, that if I was going to survive, that I would need to get involved in the search for treatments for my disease. And so I'll share the perspective of a researcher. And finally, I learned that it wasn't something I could do on my own. So Dr. Mitchell mentioned my book is called Chasing My Cure, but really we should have called it Chasing Our Cures, because I certainly wouldn't be alive today and we wouldn't have made the progress we have if it was just me chasing my cure, but it really was us chasing our cure. And this is just a photo of me with a number of other Castleman's patients. But I think that the secret sauce behind why I'm alive today, which I'll go through the course of my talk, is that we brought together patient, physicians, advocates, researchers, loved ones of patients, along with regulators and pharmaceutical companies to all work together. Those 7 different groups, bringing them together. I'm, I guess, a little unique in that I wear many of these hats, but I think the key takeaway is that regardless of whether you wear one hat or multiple of these hats, the key is to get these perspectives together, because you can make an incredible impact on an individual patient level when you get these 7 groups working together. Importantly, you can make incredible impact within a given disease and even across diseases, sharing what we learned for one condition with another. Today, I'm going to share a bit more about my personal journey, highlight how we identified a novel therapeutic target, talk briefly about this concept of personalized medicine, share some of the work beyond Castleman disease, and close out with future directions. So I'll start out by presenting a case, which you probably, or you may be able to suspect who the 25-year-old medical student is that presented to the emergency department. But this patient presented with 3 weeks history of fatigue, weight loss, and blood moles. Photographed on the screen, you can see this kind of appearance of cherry hemangiomas. 5 days of fevers, constitutional symptoms, and right upper quadrant pain. No significant past medical history. Patient was notable for palpable lymphadenopathy and also some fluid around his ankles. Labs were pretty normal, except for maybe a mildly upper limits of normal or lower limits of normal platelet count and an elevated creatinine. But given the palpable lymphadenopathy, a CT scan was done and found disseminated lymphadenopathy, hepatosplenomegaly, and fluid in the abdomen. And so I suspect many of you all are going through what's your differential at this stage. I'm sure you're thinking, well, maybe this is some viral infection like EBV, maybe it's an initial presentation of lymphoma or an atypical lupus sort of picture here. Patient was admitted. Given in particular the disseminated lymphadenopathy, and then really deteriorated rapidly. So multi-organ system dysfunction, 70 pounds of anasarca, very low albumin, renal dysfunction requiring dialysis 3 times a week, CRP over 300, an acute retinal hemorrhage that caused temporary loss of vision, elevated LFTs, anemia requiring almost daily RBCs, and thrombocytopenia requiring daily platelets, sometimes multiple platelet transfusions per day. So I'm sure a lot of different diagnoses are going through your head. Maybe you suspect one in particular, but we did call in rheumatology for a consult, and there were some notable positives, like a positive ANA, but there was no joint pain. The really specific autoantibodies weren't present. There was no improvement with corticosteroids. And the infectious disease came in and did a full workup, and all they could find was history and evidence of a prior EBV infection, otherwise Penn negative. And finally, Hem-Onc came in, and really the only notable positive was a tumor lysis-like syndrome when the patient was given high-dose corticosteroid. Otherwise, the bone marrow seemed reactive. There was polyclonal plasma cells. There really wasn't a clear etiology, and we really didn't know what was going on. So around this time, and I'll go ahead and switch from the third person to the first person and go ahead and tell you that I'm the patient. I was that 25-year-old medical student, and around the time my dad got the phone number for a doctor at the NIH. I'd been in the hospital for about 3 weeks. I was in ICU for most of that time with multi-organ failure, no diagnosis, and a family friend, actually, it was Betty Jacobs, former dean of the nursing school and a professor at Penn. Betty actually gave my dad the cell phone number for a doctor at the NIH. And my dad didn't know who it was. He wrote in his phone as NIH doc. And so he started calling this doctor every day, and every day the doctor would answer my dad's calls and spend about 30 minutes going through lab tests and what was going on, and give my dad his opinion on what we should do. And this went on for weeks and weeks, every day for weeks, on the phone with this doctor. And about 6 months later, I was eventually discharged from the hospital. And I remember asking my dad, I said, Dad, I have this vague memory from months ago that you were on the phone like every day with someone. Who are you talking to? And he said, I don't know. It's some doctor from the NIH. I think his name's Fauci. And so I Googled Fauci, Fauci, NIH, and I quickly figured out it was Tony Fauci. And of course, I'm sure you all knew who Dr. Fauci was back in 2010, but and of course he'd already won a Presidential Medal of Freedom. But my dad didn't know who he was, and my dad didn't take the time to try to figure out who he was. This is just, I think, such an awesome story of how far our loved ones will go for us during a really tough time. I've subsequently connected with Dr. Fauci a number of times, and we've laughed about how, my dad also is from Trinidad in the Caribbean and has a very strong accent. And we can just both picture my dad, saying Fauci, 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 and having no idea, who this was. Of course, so thankful for the service that Dr. Fauci's been doing throughout his career. Eventually, a lymph node biopsy was performed. I don't know how much Dr. Fauci had to do with the lymph node actually being done, but it was eventually done. And we did the lymph node biopsy because of concern for lymphoma, an aggressive lymphoma that potentially could be causing all these symptoms. And the pathology came back as Castleman disease. So idiopathic multicenter Castleman disease, a rare hyperinflammatory disorder where there is a cytokine storm that occurs for an unknown cause. Some of you all may have heard of Castleman disease before. It's named after Benjamin Castleman, photographed here on the screen. He was the first person to describe it back in the 50s. Really, it's based on this particular appearance in the lymph node. So 2 things in particular stand out. The first is lots and lots of blood vessels, so highly vascularized lymph nodes, and then very atypical germinal centers. So many of you all probably don't remember germinal centers from medical school, but germinal centers have a particular size and shape that you would expect in a normal lymph node. In Castleman disease, they're collapsed in on themselves. So the pathologist saw this and said, I think this is Castleman disease. Castleman disease really describes a group of disorders that fall within it. You can have unicentric Castleman disease, where there's a single enlarged lymph node, a solitary enlarged lymph node, that when resected, this is generally curable. Patients have mild symptoms. And then there's what we call multicentric Castleman disease, where you have multiple regions of enlarged lymph nodes all throughout your body. That can be caused by infection with a virus, human herpes virus 8. Basically, the vast majority, about 10% of the US population is infected with HHV at some point in their lives, but the vast majority will get infected and never show any symptoms. But a very small fraction of individuals that get infected with HHV, typically if they're HIV positive or otherwise immunocompromised, will develop a cytokine storm, and that's because their immune system cannot control the virus. So you get this HHV-driven cytokine storm with lots of IL-6 and viral IL-6. You can also have multicentric Castleman disease in the context of a malignancy. So poems involve the monoclonal plasma cell population that actually produces a number of cytokines. So it's actually a somatically mutated clonal cell population that's producing the cytokines that creates the cytokine storm. But then there's another type of MCD, what we call idiopathic MCD, where you get the cytokine storm just like is caused in HHV positive MCD, just like occurs in the malignancy-associated MCD, but there's no cause that we can find. There's no evidence of a virus. There's no evidence of a clonal malignancy. And so you have this idiopathic MCD. Back when I was diagnosed in 2010, there were no diagnostic criteria. So you had to just kind of hope that a pathologist knew what to look for and hope that your clinician kind of knew how to integrate these things, but there was no criteria. And so we established criteria a few years ago. You need to have multiple regions of enlarged lymph nodes. Your lymph node needs to have particular appearance under the microscope. And then you need to have at least 2 of these clinical and laboratory abnormalities that you see with IMCD. These are also quite non-specific clinical and laboratory abnormalities that you can see with other cytokine storm conditions. And as a result, it's really important to follow and go through exclusionary criteria to ensure that diseases that can mimic IMCD are ruled out. About a third of patients die within 5 years of diagnosis, and then another third will die within 10 years of diagnosis from idiopathic multicenter Castleman disease. It's a very complicated condition, as I mentioned earlier, kind of sits at the intersection of autoimmunity, malignancy, and infections. There's clinical overlap with each. There's even pathological overlap with these various other conditions. For years, we've known the clinical pathology of Castleman's. We've known the picture of what it is to have IMCD. It wasn't until the late 80s, early 90s that it was discovered that interleukin-6, one particular cytokine, is the key driver cytokine in a portion of patients. Kazuo Yoshizaki made that discovery in Japan, and even though he was able to figure out that IL-6 was the critical cytokine among many other cytokines that are also elevated in Castleman disease, there has always been a black box around the signaling pathways responsible for the excess IL-6, the cell types involved, and the etiology behind this excessive IL-6 production. So we've hypothesized that maybe there's a virus that we've never discovered that could be causing this. Maybe there's a small clonal population of cells that are producing cytokines, or maybe there are autoimmune or autoinflammatory mechanisms that are resulting in this immune hyperactivation. But a lot of people would say, you know, it's good to know what's causing the IL-6, but at the end of the day, if you block IL-6 with either tocilizumab, which blocks the receptor, or the ligand directly with siltuximab, 1/3 of patients just get better. So who cares, you know, what's the cause and what are the cell types? If you block it, you get better, and these patients do really, really well. But the reason we really care is because 2/3 of us don't benefit from siltuximab or tocilizumab. So 2/3 of us, we went from knowing that IL-6 is the driver to now a world where we don't know what cytokine's driving it. We don't know the signaling pathways. We don't know the cell types. We don't know the etiology responsible for it. So what do you do with a condition like this? Well, if you don't have anything to target, one option is to give broad cytotoxic chemotherapy, multi-agent chemotherapy, just to wipe out the entire immune system, because we don't know what to target. And so that's what we do generally for Castleman's patients that don't respond to IL-6 blockade. This is a picture of Kazuo Yoshizaki. Kazu, as I mentioned, discovered interleukin-6 was elevated. He did seminal work to demonstrate that he felt that IL-6 was a key driver. So he went on to develop a drug, tocilizumab or Actemra, which I'm sure many of you are familiar with, that blocks the receptor for interleukin-6. He did this in Japan, and he was doing this for Castleman disease. And I had heard a rumor from Makoto Ide, another physician in Japan, that Kazu had given tocilizumab to himself. He had tested it on himself to prove that it was safe before he gave it to other humans. And so I asked Kazu, I said, Kazu, I heard you gave tocilizumab to yourself. He said, no, I didn't give it to myself. The nurse, she gave it to me. So Kazu Yoshizaki made the discovery about the drug target. He developed the drug that could target the IL-6 receptor, and then he gave it to himself as the first human to receive it, really to prove that it was safe before he went on to test it in other humans, in particular in patients with Castleman disease. It went on to get approval in Japan for Castleman disease. That was the primary approval and indication. And then here in the United States, years ago, it went on to get approval for rheumatoid arthritis. And then I'm sure many of you are familiar with the story of tocilizumab for CAR therapy. This is a picture of Emily Whitehead. Emily was the first pediatric patient to ever receive CAR therapy just next door at the Children's Hospital of Philadelphia. And Emily was dying in the ICU with a cytokine storm, and a few of my colleagues decided to try tocilizumab, this drug that Kazu developed years before for Castleman's, decided to try it to treat Emily, and it saved her life. And I often say that if tocilizumab had not been used for Emily, had not saved her life, then I suspect the entire cellular immunotherapy and CAR therapy program would have been sidelined for at least 5 or maybe even 10 years. And then when the COVID pandemic emerged, a number of physicians in China and elsewhere began using tocilizumab in the most severe cases. And early on, there were a lot of really positive anecdotal reports, and then there turned to a number of negative, large clinical trials. However, more recently, what's become clear is that the trials that were negative of tocilizumab in COVID were trials that included patients newly admitted to the hospital early on in the course of their severe COVID. But what we've subsequently found is that if you administer tocilizumab closer to the time of admission to the ICU, so in the most severe cases, there is a mortality benefit. And so this is just a great example of a drug developed for a very rare disease, Castleman disease, many decades ago, and now having a really outsized impact in rheumatoid arthritis, CART therapy, and even the most severe COVID patients. For me, I got siltuximab, I got that IL-6 blocker. Unfortunately, it didn't work for me while I was critically ill. And so I got multi-agent chemotherapy, adriamycin, Cytokine, etoposide, Velcade, dexilutamide, Rituxan. That combination of 7 drugs put my disease into remission. You can see here my dad and I smiling next to one another. I'm sitting up for the first time in a long time. You can see that I've still got a really big belly. I was getting dialysis 3 times a week at the time. And I still had a ton of, and I was actually getting my belly tapped 3 times a week, and 5 to 7 liters pulled from my belly with each tap. But you can see it's still really big. But on this particular, the photo on the right, that particular evening was New Year's Eve 2010. And at this stage, I've been sick for quite some time. And about 8 p.m. that night, my dad and I decided to take a walk around the hematology oncology floor at the hospital that I was at. And as we passed the family waiting room, we saw that there was a gentleman who was clearly drunk. He was like kind of swaying in his chair. And in our next lap around, we saw that he had fallen onto the ground. So my dad ran over to this gentleman and helped him back into his chair. And he looked at my dad and I, and he said, "Thanks so much. Good luck to you and your wife." I said, "Wife? What is this guy talking about?" And then I looked at my belly and I realized that he thought that I was my dad's pregnant wife and that we were walking laps around the hospital to deliver our child on New Year's Eve, which was a low point emotionally for both of us. But we managed to laugh really hard. And I highlight this story because I'm sure all of you have, I know all of you have gone through challenges with your patients, and I'm sure some of you have found that laughter in the midst of really tough times, especially with the people you love, can be really helpful. So about 7 weeks later, I was discharged from the hospital, and you can see here maybe how someone would have confused me as my father's pregnant wife with my big belly and my bald head. And then this is a picture from my days playing quarterback at Georgetown. And Mitchell made a comment about this, or Dr. Mitchell made a comment about this earlier, that this is definitely one of my glory days photos, because I certainly have more of a dad bod these days. But I do think that this could be a great advertisement for like Peloton or Muscle Milk if the photos were reversed. But unfortunately, they're definitely in the wrong order. I did eventually get out of the hospital, start taking a picture every week, and you can see the fluid starting to go away. You can see my hair starting to grow back. And about 6 months later, I recovered. So about a year, there's one full year that I was on medical leave while I was recovering from the 6 months that I had been hospitalized. And I was on that experimental drug, siltuximab, that it didn't work for me acutely, but we hoped that maybe it could prevent a relapse. Maybe this could be a good maintenance therapy. I eventually returned to med school at Penn on this drug, and Dr. Mitchell mentioned Arthur Rubenstein. Arthur had just retired as dean at Penn and was made the interim director of the Orphan Disease Center. And I went to Arthur and I said, "Arthur, I've got an orphan disease. I'm on an orphan drug." As Dr. Mitchell mentioned, for the last 10 years, I've been building and growing a nonprofit organization. I would love to be a part of the Orphan Disease Center and to work with you. And he very graciously allowed me to join the team. And it was a great opportunity to get a sense for all of the challenges and opportunities within rare disease research. This was back in 2012 when there was even less interest than there is now. But in the midst of this work and being back in med school, I relapsed. And so I relapsed and nearly died for the fourth time. But what was so tough about this relapse was that I was on that drug Cytokine, the drug that we were so hopeful would keep my disease in remission. And so now I had officially run out of options. And my doctor explained that to me, that there were no more drugs in development. There were no more promising leads. There really was no reason to be hopeful. And when my doctor left the room while I was getting multi-agent chemotherapy, I told my dad, my sisters, and my girlfriend at the time, Caitlin, that I would dedicate the rest of my life to trying to find a treatment that could be helpful for me. And the first thing I did was get involved in conducting laboratory research. No one was studying Castleman disease at Penn, but there was a researcher in pulmonology that gave me some space in her lab. And I started a foundation called the Castleman Disease Collaborative Network, with the goal being to bring together physicians, researchers, and patients from around the world to advance research and treatment for Castleman disease. And I did want to highlight this one passage from Chasing My Cure, and that's because this was such a critical moment in my journey. It's when I realized that hope cannot be a passive concept. It's a choice and a force. Hoping for something takes more than casting out a wish to the universe and waiting for it to occur. Hope could inspire action. And when it does inspire action in medicine and science, that hope can become a reality beyond your wildest dreams. And this was such an important moment for me when I went from being this hopeful medical student who believed that some researcher somewhere would find a drug that could save my life, to saying, if I'm going to hope that some researcher somewhere will find a drug that could save my life, maybe I should get involved in doing something about it. Maybe I should start taking some action. And that really was the beginning of moving in the right direction. So where were we back in 2012? Well, there's about $10,000 a year being spent on translational research for Castleman's. No NIH money had ever gone towards IMCD. No patients in a registry, because there wasn't a registry. There were two organizations that were in the Castleman space, but neither of them had any sort of a research plan or agenda. There were no cell lines, animal models, biobanks. Many questions existed. No diagnostic criteria, as I mentioned, no treatment guidelines, no predictive biomarkers to predict who is likely to benefit from IL-6 blockade versus particular chemotherapies, no FDA-approved treatments, and one drug in development, that drug Cytokine, which is, as I mentioned before, is a kind of a next-generation version of tocilizumab, which targets the ligand for IL-6, or IL-6 ligand directly, but that one drug in development didn't work for me. And so the position we were in was we had a lot of work to do to find treatments for patients like me. So one of the first things I did was to hold a webinar for a bunch of Castleman's patients. And then I had this webinar and I decided I was going to show a picture of a Castleman. I mentioned Castleman disease is named after Benjamin Castleman, but we've kind of repurposed the idea of a Castleman to be a man in a castle or a kind of a warrior sort of image. And so I showed this to a bunch of patients, and during a webinar, they're like, yeah, we want to get behind the CDCN. We love what you guys are doing. We love the Castleman. And a couple of weeks later, this showed up on our Facebook page. So one of our patients had screenshotted the image and then got it tattooed on his shoulder. And I always say, if this is not patient engagement, then I don't know what patient engagement is. But the truth is, our patient community was just waiting for something to get behind. In addition to patient community and connecting them, I knew I would need to build a team, and I would need to build a large volunteer army. So I was a medical student at first, and then I went on to business school. And so I turned to my classmates in medical school and in business school to join our team, to be a part of advancing research and treatment for Castleman disease through a very different way that we do research. I don't have time today to go through what's called the collaborative network approach, but basically we crowdsource research ideas from the community, and then we go out and we recruit the best people in the world to do our studies, as opposed to the traditional RFP approach where you raise money and hope the right people apply for the right project at the right time. And in this picture, you can see we're doing what we call the Castleman Flex. If we were all in person, I would ask all of you to stand up and do a Castleman Flex with me. But I guess all I can hope for is that maybe you'll do a Castleman Flex in front of your camera, take a picture, post it on social media, help us to raise some awareness about Castleman disease. Once we had the patient community, our volunteer army, the next area to focus on was the physician researcher community, and really connecting physicians and researchers around the world through an online portal, and also through in-person meetings. We now have over 800 physicians and researchers that are part of our network. If you see Castleman's patients, if you study Castleman's or related conditions, I really hope you're part of our network. If you're not, please email me. Would love to include you. And we have a really active online community, and it's been so meaningful for so many of us to work together. So the kind of framework that we have for the work that we do is the CDCN is really the heart of what we do. It's connecting that community of scientists, physicians, researchers all together in one place. And then we really focus on dissecting biology of Castleman disease. What is happening in Castleman disease? But you can't start to dissect the biology of Castleman disease unless you have really high quality biospecimens. So we can send Castleman's patients around the world by telephone, by email. We've even consented a few Castleman's patients at Georgetown, where we can consent them to provide us with either blood samples or excess tissue from lymph node biopsies. We get those high quality biospecimens, we process them to make them available to any researcher around the world. In parallel, we enroll these patients into our Accelerate Natural History Registry, meaning that for every biospecimen we get, we now have between 3,000 and 4,000 data points from that patient's complete medical history that can be correlated with those biospecimens. And then we use the biospecimens and the clinically annotated data to then perform translational research. And that's based on what our community prioritizes, the most important research. Within that agenda is both discovery level research, omics approaches like serum proteomics, which we've done a lot of, all the way through hypothesis-driven approaches around mTOR, JAK-STAT signaling. But really, it's about leveraging high-quality data, biospecimens to push forward the science as quickly as possible. And as we learn things about Castleman disease biology, the next step is to ask the question, well, what drugs already exist that are already FDA approved that could maybe modulate the thing that we're interested in? So if it's a pathway that's too activated, is there something that'll suppress it? The pathway that doesn't seem activated enough, is there something that can augment it? And we always ask the question, are there drugs that are already FDA approved? And we publish our research, and oftentimes clinicians will try a drug off label. This is a deadly condition with few options. And so drugs are tried off label for Castleman's. And when they are tried off label, we make sure that we get that data into Accelerate. Accelerate, as I mentioned, is this incredible opportunity to get all this medical data in one place. And so if drugs are going to be tried off label, we feel very compelled that we should be able to do everything we can to make sure that we can get that information. Next, we move the most promising drugs onto clinical trials. We have a trial open right now called RAPID, and I'll be mentioning that a bit later. And then we use that information about what drugs work, what drugs don't work, to start to be able to predict which drugs are going to work in which patients. And then we can feed all this information back to our understanding of biology. If an IL-6 blocker improves someone's symptoms, then you know that IL-6 was a disease driver. If IL-6 blockade doesn't improve symptoms, you know that IL-6 is not the disease driver in that patient. So we use the modulation of therapeutic targets to really give us a sense for whether one aspect of biology is important or not. I would love to go through all of our research studies, but I will encourage you to go to cdcn.org/research. You can take a look at all the studies underway. There was one study underway when we started back in 2012, and now they're well over 30. I'll transition now into the identification of a novel therapeutic target. In between all this work for the CDCN, I graduated from medical school. I got engaged to Caitlin, who's in the picture here with me. I started business school as I continued to conduct research into Castleman's. And then just a few months into business school, I relapsed and I nearly died for the 5th time. This picture is actually taken at Caitlin and I's engagement party, which was taken in a good friend of mine, Fran Buckley, who's a Georgetown alum and a wonderful friend and supporter of the Georgetown community and also of me. This is at our engagement party at Fran's house. You can see I'm bald because in the time between these photos, I had relapsed and nearly died for the 5th time and spent a month hospitalized in critical condition. And so when I got out of the hospital and I had just gotten multi-agent chemotherapy, I was out of options. I knew that there was no way I was going to make it to our wedding date if I didn't find a drug that could help to keep me in remission. I'm going to fly through this slide in particular because you can actually go to the citation at the bottom of the page for more details on my particular journey in finding this treatment. But I will highlight that what I try to show here are the number of different drugs that were used in my case. Each vertical dotted line represents admission to the hospital, and I spent most of that 6-month period hospitalized. And a number of drugs were used, like steroids and rituximab and IL-6 blockade, adriamycin, cytoxin, etoposide, Velcade, dexthalidomide. A number of drugs were tried. It was the chemotherapy that gave me a nice year-long remission, but then it was chemotherapy that I needed again for another year-long remission before relapsing again and nearly dying for the 5th time. So at this stage, I really was out of options. What do you do when you've basically failed to respond to every drug that's ever been reported to be used for Castleman disease? Well, what you do is you have to find new data, you have to generate data, you have to find some sort of signal or lead to go after with a treatment. And so we've been performing cytokine panels on my blood every few weeks leading up to my 5th flare. And what we found is that during the flare, all of my cytokines were elevated. But what we found was interesting is that 2 of those cytokines began to rise in the weeks and the months leading up to that relapse. So one of them is VEGF, vascular endothelial growth factor. The other one is soluble IL-2 receptor, which is a marker of T-cell activation. And so we thought that was pretty interesting. You know, the fact that these things sort of paralleled and began to rise before I began to have symptoms, maybe they're involved in pathogenesis. So I had stored some blood samples. I actually also had a lymph node biopsy performed when I was relapsing, with the hope that if I were to survive, that I would then have tissue to run experiments on. And so I went back to those samples, the serum, the PBMCs, and the lymph node, and I ran a series of experiments and was able to confirm, in fact, there was increased T-cell activation in my PBMCs. VEGF was one of the most elevated proteins in my blood, even when we expanded the panel to over 1,000 proteins. And what was interesting about this is that the clinical picture certainly correlated with what we were finding in the lab. So I mentioned earlier that my lymph node is highly vascularized. That's part of diagnosing Castleman disease. Well, that certainly would be consistent with having elevated levels of vascular endothelial growth factor. I also mentioned those cherry hemangiomas. This would be consistent with having elevated systemic levels of VEGF. And finally, capillary leak syndrome. This is, excess fluid accumulation, which can oftentimes be related to VEGF. So the question became, is there some sort of final common pathway involved in the cytokine production we observed, the T-cell activation we were seeing, and the VEGF production? What could link these together? So we ran this data through a series of pathway analysis tools to look for potential candidates that could explain the proteomic picture and really just what we were seeing generally. And what we found through looking at a number of different databases is that the PI3 kinase AKT-mTOR signaling pathway was identified as a candidate driver, regardless of what database we looked at. And so this became really interesting because mTOR is actually really critical for T-cell activation, for VEGF expression, for cytokine production, for immune cells. So this idea that maybe mTOR could be turned on and explain what we were seeing clinically became really interesting to us. But there was one really important step left, and that was to really validate that there in fact was increased mTOR. So I ran an experiment, a really simple and cheap experiment, immunohistochemistry for a protein called phospho-S6. Phospho-S6 is a readout of mTOR activation. So the more phospho-S6, the more mTOR activation you've got. So I ran this on a bunch of normal lymph nodes first, a bunch of reactive lymph nodes. And what I found is that and brown is positive. So there certainly were cells that had mTOR activation in the lymph node of normal people. There were absolutely mTOR activated cells. But then when I say in my lymph node, I was just blown away by how much more mTOR activation there was in my lymph nodes than we saw in our control samples. And so this didn't guarantee that blocking mTOR would be effective, but it meant that this was a rational target, that it would be one could assume that because there's so much mTOR activation and mTOR is involved in cytokine production, T-cell activation, and VEGF production, that maybe blocking it could be effective for treating this disease. And so I started taking sirolimus 86.19 months ago that I've been in remission. And I say 86.19 months because I know that I can't round up. I don't know how long sirolimus is going to work for me. I don't know if I'm going to make it to 87 months in remission, but I also refuse to round down. I'm so thankful for every fraction of a month, a week, a day of remission that I've had. And of course, thankful for remissions for so many other patients, especially when you consider it in the context of how long my previous remissions were. It really feels like we've made a big leap here. During this remission, the New York Times described this as Dr. Cure Thyself, which I think is a bit of an overstatement. I think it should be doctor helping himself a little bit right now and hopefully for a lot longer. But importantly, during this period, Caitlin and I were able to get married. We made it to our wedding day. We got married on May 24th, 2014. My hair grew back just in time. That's never before been cut hair. That's in that picture. That actually was pretty important to me. I wanted to have hair on my wedding day because I didn't want the external reminder for me or for Caitlin of what I had just gone through or what I would likely continue to put Caitlin through. A couple of years ago, Caitlin and I had our daughter, Amelia. This is a picture of Amelia around her first birthday. And this is Amelia at Halloween just a few months ago. Amelia is dressed as Amelia Earhart, and we are her aviation crew, which I think is like a perfect symbol and analogy for what it's like in our household. Amelia is the boss, she's the pilot, and Caitlin and I just do our best to try to keep her going in the right direction. During this remission, I also joined the faculty at Penn, where I launched a center called the Center for Cytokine Storm Treatment and Laboratory. Initially, that center was focused on Castleman disease and the cytokine storm that we see in the setting of CART therapy, which of course is something that we do a lot in Philadelphia. But of course, this past year with the emergence of the COVID pandemic, cytokine storm in the context of COVID-19 has become something that we've spent a lot of time on. And in fact, launching something called the Corona Project, which you can visit cdcn.org/corona to learn about the work that we're doing. It's the world's largest database of every drug that's been used to treat a COVID-19 patient and all of the data for or against the continued use of drugs that can be repurposed for COVID-19. Here, many of you are wondering about mTOR in other Castleman's patients. Well, we ended up publishing in JCI a couple of years ago the discovery of mTOR as a therapeutic target, the use of an mTOR blocker in the first 3 patients. And then last year, we published about how we expanded our mTOR work from just 3 patients to 26 patients. And then also published around a potential candidate driver. What could explain why the mTOR why there is so much mTOR activation. And we think that increased type 1 interferon signaling for an unknown cause seems to be associated with a potential driver of the increased mTOR activation. So given these data, we have treated a number of other Castleman's patients with sirolimus. I showed a photograph here of Joey. Joey is a young patient who showed up to the Children's Hospital of Philadelphia, not responding to treatment. First-line or second-line therapy for Castleman's. He ended up having a really positive response to sirolimus. This is a picture of him with his 2 younger siblings. Unfortunately, for every 1 patient like Joey, we find that about 2 patients don't respond to sirolimus. So we're somewhere around about 1/3 in the response rate that we were seeing. And so I wanted to highlight just 2 of those patients that really do stick out to me that I think about all the time. Lisa and Sergio, both of them didn't respond to first or second line therapy. We tried sirolimus, we tried chemotherapy, and nothing worked. And we were not able to save these 2 young people's lives. And so it's patients like Sergio and Lisa and the many others like them who don't benefit from existing therapies that we really focus all of our attention on trying to find solutions for. So I don't have too much time left, and I want to leave time for questions, but I want to take a moment just to talk about this idea of personalized medicine. I mean, you're all aware with the traditional approach where, one drug is given to a group of people, some people respond, some people don't. And also you're aware of the kind of the personalized medicine approach, which I think is sometimes overused, but it's the idea that we can run tests to figure out who's likely to benefit from drug A, drug B, and drug C. And if we want a world like this for Castleman disease, we need to better understand what are those biomarkers that can help to predict one drug versus another. And we have to figure out more drugs that work, because if you only have one drug that works, who cares about the biomarkers? But if we can figure out biomarkers for who benefits from that drug and then identify additional drugs for people who won't benefit from it, that's, I think, getting us closer to what we're all hopeful for. I thought I'd share some preliminary data from a paper that will hopefully get accepted soon. We basically did serum proteomic profiling on a large number of Castleman's patients, measured over 1,100 different proteins in these patients. And what we found was that IMCD, not really that surprisingly, is quite heterogeneous. So if you just ask the data simply, do these samples cluster with one another? The data suggests that there's at least 6 clusters of patients that have proteomic profiles that are similar to one another. And then if you ask, okay, among these different proteomic profiles, are there certain profiles that are associated with benefit or response to cetuximab, this one drug that's approved. And what we found is that, yes, there's one group, what we call cluster one, that has an over 60% response rate to cetuximab versus all comers, which is more like a 34% response rate. So if you just give everyone with Castleman disease cetuximab, 1 out of 3 will benefit. But if you do this profile ahead of time, you pick out the cluster one patients, you'll be able to double your likelihood of one of these patients benefiting. We were able to then take the 1,300 proteins down to a 7-analyte panel and validate that, in fact, higher your cluster one score, the more likely you are to benefit from cetuximab. But as I said earlier, knowing who's going to benefit from cetuximab or not is only helpful if we actually have alternatives for people who aren't going to benefit from cetuximab. And so we use the proteomic data to look for novel therapeutic targets. And what we found is that, as we expected and hoped, we found that IL-6 signaling, or IL-6 JAK-STAT, was enriched in people who benefit from an IL-6 blocker. I mean, that makes sense, right? You know, if you get better when you block IL-6, then IL-6 is probably the driver. And so we were pleased to find IL-6 as one of the most enriched pathways in our responders. And then we asked, well, what are the enriched pathways in the non-responders? And we were surprised to see IL-6 JAK-STAT signaling again in the non-responders, because these are people who didn't benefit from IL-6 blockade. And so we dug into the data a bit more. We started studying JAK and STAT signaling in our Castleman's patients, and we find that regardless of whether you benefit from cetuximab or not, there's increased STAT3 activation. So the pathway is getting activated whether you're a responder or a non-responder, which really suggests that maybe there are some other ligand other than IL-6 that's driving the JAK-STAT, or maybe it's a problem downstream of the cytokine. Maybe it's a pathway problem as opposed to a cytokine problem. And so when I go back to that framework I showed earlier, I think that what we've shown quite strongly is that IL-6, JAK-STAT3 seems to be an important aspect of Castleman disease pathogenesis. I think I've also shown that mTOR and VEGF seem to be important as well in IMCD. We know you can block cetuximab with IL-6. We know you can block sirolimus with mTOR, and that these drugs can work for some people. But there still are a lot of people who don't benefit from either approach. So there's some sort of kind of alternative pathway that we haven't identified yet, and we think that we may have. We think that JAK might be a central node. JAK1 and JAK2 in particular might be a central node involved in both the STAT3 activation, the mTOR activation. And so you can think about drugs like ruxolitinib that are really exciting to hit both. I'm running low on time, so I'm going to go quickly through this, but you can see where we were back in 2012. Then I'm going to superimpose where we are today in 2021. We've raised about $1.5 million for research, which has led to an additional $10.1 million in investment from external organizations, from foundations, from the federal government, from pharmaceutical companies. The NIH gave my lab the first ever Castleman's grant in R01 a couple years ago. We now have over 1,200 patients in our registry. There were 2 organizations. We came around, so for a little while there were 3, but now we've all unified into one collaborative network. We've got a biobank. We're making progress. The questions remain. We published the diagnostic criteria a few years ago that, like I shared, published treatment guidelines a couple years ago, published predictive biomarkers a couple years ago. Cetuximab, that IL-6 blocker, got approved here in the US back in 2014. And now there are 2 drugs in development. The drug I'm on, sirolimus, where we have an open clinical trial for IL-6 refractory patients, and also this idea of going after JAK with a drug like ruxolitinib. I really don't have time to get into our work beyond Castleman's and thinking about COVID, but I do want to highlight the patient on the left of the screen here is a very sick Castleman disease patient with what's called the Tafro syndrome, the most severe case of Castleman disease, on a ventilator, on dialysis, in the ICU. And the patient on the right is a COVID patient on a ventilator, on dialysis, in the ICU. And if you look at their peripheral blood mononuclear cells, the activation states are very, very similar. So this immune hyperactivation that we see in COVID in the most severe cases parallels in many ways the hyperactivation we see in Castleman's. There's been a lot of debate around, is cytokine storm the right term to use when we think about COVID? And I think the bottom line is no. Cytokine storm does not describe the vast majority of COVID patients. The vast majority of COVID patients do not have a cytokine storm. However, the most severe COVID patients who benefit from corticosteroids or baricitinib or tocilizumab, I think by definition, they have a cytokine storm because they get better if we give them immunosuppressive therapies. And part of the debate that was really hard to have was that there was no definition for what is a cytokine storm. So Carl June and I wrote an article for the New England Journal a few months ago defining what is a cytokine storm, really the first unifying definition for cytokine storm. If you haven't read it, I hope you will, and let me know if you have any thoughts. Really don't have time to go through it, but really we lay out what is a cytokine storm. There are a number of ways you can get to a cytokine storm, but what does it involve? What are some of the therapeutic targets? And how can we think about cytokine storms as an umbrella? Forget about the titles we like to put on things and think a little bit more in terms of what are the therapeutics that would be helpful for various cytokine storm disorders. And I also mentioned that we got very involved in the COVID-19 drug repurposing world, launching this Corona project. I now serve on both an NIH and an FDA working group to select drugs for large clinical trials of COVID. And we utilize this huge data set that I don't have time to go through today. But basically every drug that's been given to any COVID patient worldwide is in our database. It's free, open access, being utilized by researchers around the world. And we're really leaning on our experience from Castleman disease to inform the way that we think about COVID. So do check out our New England Journal paper and also our Corona project. I will skip over this and just say that in COVID, it's all about an appropriate immune response. You don't want too strong of an immune response. You don't want too weak of an immune response. And there are drugs like baricitinib and dex that can get you closer to that middle ground. Drugs like inhaled interferon, they can get you closer to that middle ground. So this is my last slide. I just wanted to close with a handful of lessons from my journey. So as Dr. Mitchell mentioned in the beginning, I wrote this book, Chasing My Cure, a few years ago. It came out about a year ago. I wrote it because I learned so many lessons from my journey chasing after my cure, lessons that I felt were particularly relevant for those in the medical community and also patients, but really anyone who's struggling with life and life's challenges. So I thought I'd highlight a handful of lessons. The first is that hope can have many different forms. There's the kind of hope that helps you to keep fighting, which I had at many times. I got that sort of hope and strength from my family. But there's also the kind of hope that inspires you to act and to take action. And that I think is really what my book's all about. And I made that the subtitle of the book, is A Doctor's Race to Turn Hope into Action, because I think that's such an important message. The second is that I hope no one watching this video is ever confused as your father's pregnant wife. But if you are, I hope you can find some laughter in that. Laughter can be so powerful during really, really tough times. The third is how important it is to communicate our limits. My doctor explained to me how little was known about Castleman disease. That led me to want to get involved. The fourth is that solutions may be hiding in plain sight. The drug I'm on had been around for decades and no one had ever tried it for Castleman disease. How many more drugs are there out there that could be used in new ways? And this is just one schema to highlight that there's over 2,500 FDA approved drugs for about 3,000 human diseases, but there's about 7,000 human diseases that don't have any approved drugs. And maybe these drugs could be repurposed. And finally, I mentioned at the very beginning, my book should have been called Chasing Our Cures, because it really has been a team effort. I hope all of you, part of this will be a part of our Chasing Our Cures Army, help to raise awareness about our Castleman's work, our COVID work. You'll check out Chasing My Cure and help us spread the word about our message and our lessons of hope. So thank you all so much. I think we have a little bit of time for Q&A. And of course, I have to thank my amazing team who's a part of this work.